everything, of what we do every day. Mental health is one of the biggest issues facing our country. It's certainly a big issue in my home state of Montana. It's certainly a big issue for our veterans. That's why it's critically important VA does absolutely everything possible to connect more veterans with the mental health care and the suicide prevention that they need, regardless of where they live. The latest data shows that 2020 had the lowest number of veteran suicides since 2006. That trend needs to continue. The data shows that more than 60% of the veterans who died by suicide in 2020 had no recent engagement with the Veterans Health Administration. That means the VA must work harder to get our veterans into the system. In recent years, Congress has advanced critical legislation. I was proud to champion many of them, including the John Scott Hannan Veterans Mental Health Care Bill, Veterans Health Care Improvement Act that I did with Senator Moran, and the Strong Veterans Act of 2022. These laws have helped the VA's mental health workforce and programs, including through alternative and local treatment options. But the fact is, we have much more to do. That's why I recently introduced the Not Just a Number Act to require the department to provide a more fully picture of the factors contributing to veteran suicide. By making the Community Care for Veterans Act would also strengthen veterans' access to life-saving residential treatment programs for mental health and substance abuse disorder. Congress continues to do its part by giving VA the proper funding for mental health and suicide prevention programs and ensuring it has the tools to meet the veterans' needs. And while the VA has made progress, we still have work to do. VA has been too slow in implementing the Hannan Act's telehealth grants that would improve rural veterans' access to mental health care by increasing the number of locations that can provide VA telehealth services. That's a particular concern of mine, given Montana has one of the highest rates of suicide in the nation. A nearly 5-year implementation timeline is far too long, and I'll expect an update on that initiative today. I'm also looking for an update on the Veterans Crisis Line. The Strong Act included my Reach for Veterans Act to improve the Veterans Crisis Line oversight. Last week, a new IG report was released raising more concerns about the Veterans Crisis Line. The Veterans Crisis Line is a life-saving resource for veterans, and it must be a top-performing entity within the VA. But as made clear by recent IG reports, it simply is not. I expect an update from the VA on how it is implementing the provisions from the Strong Act and how it's executing the IG's latest recommendation. Finally, I was recently informed of a death by suicide of a longtime VA employee in Montana. That employee, like so many at the VA, was a veteran. VA employees deal with stressful topics and events each and every day, and they face a lot of the same challenges as the veterans they serve. As the department continues to improve its mental health service for our veterans, I call on you to redouble its efforts to care for its workforce across the enterprise. A workforce that feels understood and supported will be far better positioned to accomplish the mission of delivering vets the care and the benefits they have earned. Senator Moran is not quite here yet, so we will start with the first panel, and then we'll yield to him when he gets here for his statement if he chooses to make it. The first panel is, I would like to welcome VA's lead witness, Dr. Matthew Miller, the Executive Director of the Suicide Prevention at the Veterans Health Administration. He is accompanied by Dr. Susan Black, a Suicide Prevention Officer at the Outreach, Transition, and Economic Development Service of the Veterans Benefits Administration. So we'll start with you, Dr. Miller. You may proceed. You've got 5 minutes. Know that your entire written statement will be a part of the record.
Thank you, sir. Good afternoon, Chairman Tester, Ranking Member Moran, and distinguished members of the committee. Thank you for the opportunity to discuss the department's efforts to implement legislation related to veterans' mental health care and suicide prevention. I want to thank this committee for its support and continued collaboration on reducing veteran suicide. This critical relationship is reflected in the resources that the Congress has repeatedly secured for VA. In 2020, 44,298 adult Americans died by suicide. Of those, 6,146 were veterans. These numbers are more than statistics. They reflect veterans' lives prematurely ended, which continue to be grieved by family members, loved ones, and the nation. Suicide is a complex problem with multifaceted and interweaving contributing factors. Suicide is not just a mental health issue. With no single cause, there is no single solution to suicide for veterans. Yet one veteran suicide is one too many. VA cannot do this work alone. In order to address individual, relational, community, and societal risks and protective factors, VA is collaborating with other federal agencies, public and private partnerships, government at local, state, and national levels, veteran service organizations, and local communities. Together, we're implementing a full public health approach as outlined in the White House strategy and VA's 10-year national strategy for preventing veteran suicide. These guiding documents are operationalized through VA's Suicide Prevention 2.0 initiative, Suicide Prevention Now, and emerging innovations combined with research and program evaluation. Further implementation of new laws, including the STRONG Act, Hannon Act, Compact Act, the National Suicide Hotline Designation Act, are all critical part of these efforts and mentioned by you, sir, at the outset. For example, Hannon Act Section 201 established the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program, allowing the VA to provide grants to expand suicide prevention services to veterans and their families to reduce the risk of suicide. In September 2022, VA awarded $52.5 million to 80 community-based organizations across 43 states, DC, and American Samoa. A second round of grant awards was announced today, ensuring reach to veterans across the nation, not just those engaged in VA care or benefits. Additionally, the STRONG Act contains more than 24 sections that further supports veterans' mental health care and suicide prevention, including further strengthening of the Veterans Crisis Line. In July of 2022, the Veterans Crisis Line rolled out 988 Press 1. VCL prepared for the implementation of 988 Press 1 by hiring over 900 individuals, responders, to address increased demand and to increase quality assurance and program evaluation efforts. Since that launch, VCL has fielded over 1 million calls, texts, and chat messages. On that note, and before I close, I want to acknowledge the recent OIG report of a veteran's death by suicide following and in the context of a contact with the Veterans Crisis Line. I as a veteran, grieve the loss of this veteran. From the painful lenses of retrospective review, we wish we could have done some things differently. It's our earnest desire and pledge to apply the wisdom gained through this review to strengthen processes as we continue to serve veterans who are at the center of all we do, even at this very minute as we answer calls. Mr. Chairman, this concludes my remarks. My colleague, Dr. Black, and I are prepared to address any questions that you may have.
Dr. Miller, thank you for your testimony and thank you for being here. I will yield my time to the wily young veteran, former chairman of this committee, Senator Murray.
Thank you very much, Mr. Chairman. Let me just, first of all, thank you both for being here, but the fact that nearly a third of women veterans experience sexual assault or harassment while serving our country in uniform is really staggering. And unsurprisingly, we know that military sexual trauma is a significant cause of mental health issues for these women. In fact, women who are survivors of military sexual trauma are 9 times more likely to develop PTSD than other women veterans. There was a 2018 VHA directive that requires all VA facilities to have a designated coordinator to help veteran survivors of military sexual trauma access mental health care and other resources. But in my home state of Washington, the Puget Sound VA, which treats, by the way, more than 65,000 veterans, doesn't does not have a full-time person in this position, which seems notable for a facility of that size and a position that's so important. So, Dr. Miller, I want to ask you, what steps is VA doing and taking to make sure that all VA facilities, including Puget Sound VA, have enough resources to assist and reach out to survivors of military sexual trauma?
Thank you for the question, Senator. I agree with you 100%, as does the VA in suicide prevention, that addressing military sexual trauma is critically important and a key component of suicide prevention. Exactly what you said, there is increased risk with regard to suicide in this area. We, at the national level, have a policy in place, requirements at the local level regarding the very points of contact that you mentioned. We receive regular reports on a quarterly basis regarding staffing, and then we work with local facilities through the VISN with regard to gaps or shortages.
So is my VA facility going to get a coordinator or not?
Your VA facility should be receiving a message stating, tell us what the plan is to fulfill this FTE 1.0.
When will that occur?
I don't know the exact timing of that vis-a-vis the current date. I would imagine by the end of the quarter or the start of the quarter, but I'd be happy to check on the
If you
specifics.
can get back to me and tell me specifically when that's going to happen, I'd appreciate it.
Yes, ma'am.
Thank you. Let me ask about homelessness. There's 33,000 veterans experiencing homeless in the U.S., 1,500 of them in my state. Veterans who have experienced homelessness are 4 times more likely than other veterans to attempt suicide. And I know the VA has made progress in reducing the number of veterans who lack housing, but we also need to make sure that we are utilizing our knowledge of risk factors and engaging with these veterans to help prevent them from experiencing homelessness in the first place. So, Dr. Miller, what is the VA doing right now to reach out to veterans who are experiencing homelessness and provide them with the mental health services that they need?
I think that the answer to that question, ma'am, starts with identifying where are veterans at the highest risk for suicide within that particular situation. And what we've learned is that veterans are at the highest risk for suicide 30 to 60 days prior to homelessness status or losing their home. So a big part of the issue for us is identifying veterans who are at high risk.
How do you do that?
I think that it's an issue of measuring and monitoring through the homeless program office at the local level up to the national level. It's happening. I don't think that it's perfect because it's very difficult to identify 100% who's at risk within 30 to 60 days. We had a situation that we faced this week where I assisted, along with some other colleagues, a veteran and his spouse who found out within 5 days that they were losing their home. We put them in direct contact with resources and assistance, but the timing can be very short. There's areas for improvement there, and we're committed to working on them.
Okay, well, Congress and the VA have put a lot of effort into reaching out to veterans with the message that it is okay for them to ask for help, that when they are feeling alone, when they're feeling depressed, there's people and resources available for them. So it's really concerning to see on the VA's website that the wait time for a mental health appointment at the Puget Sound VA Medical Center is over a month long. I've personally had veterans tell me that they've had to wait as long as 3 months just to get an appointment. I know it's challenging, I know it's complicated, but what is the VA doing to make sure that veterans who are experiencing a mental health crisis access the care they need when they need it?
Same-day access is the first step that should be in place at every local facility regarding this. Following same-day access, attending to staffing and ensuring that staffing can accommodate the demand.
Okay, but it's not happening, so what do we do?
Then we, from a national level, we consult, we offer consultation to the local level regarding where they're seeing barriers, where they're seeing impediments to access, and assisting them with constructing a plan, an action plan for following through and making improvements.
Okay, can I get you to get in touch with the Puget Sound VA Medical Center and find out why these wait times are so long and follow up on what we're going to do to fix it?
Absolutely.
Thank you.
Senator Moran.
Chairman, thank you. I'll forego my opening statement and maybe make a few comments at the end, but let me ask questions of Dr. Miller. Dr. Miller, the Office of Inspector General published a report last Thursday, September the 14th, detailing deficiencies at the Veterans Crisis Line and how the crisis line staff failed to take appropriate action with a veteran who died by suicide that same night, the night that he'd contacted the crisis line. The report also details significant issues with the Veteran Crisis Line leadership and some staff. What are you doing personally to make certain that the deficiencies detailed in the Inspector General's report are fixed quickly?
Thank you for the question, Senator. We're better than what was depicted in that report, and we have to do better than what was depicted in that report. Personally, since you asked for that particular perspective, when I was first presented with this situation with a call from OIG directly telling me about their concerns, I enacted pulling the responder from responder duties and initiating a full review of the work. That became what you see with responder 2 and 3 in the review and the report. From that time, we've been working very aggressively to make changes such that to the point right now, there's 11 recommendations specific to the Veterans Crisis Line in this report. We have made significant progress on 8 of the 11. There are 2 that involve close collaboration with the Office of Information and Technology. There's 1 that involves new information from a personnel perspective that we're pursuing.
Dr. Miller, what would be your, why does it take an Inspector General report for this to be addressed? What's not taking place at the VA to get this solved before this particular veteran committed suicide?
There are aspects of this situation that involve standards and expectations that are new to the field of crisis call. For example, text retention. Text retention is not a standard for the National Suicide Prevention Lifeline, nor is it known how many even in the Lifeline engage in text retention. It also has significant challenges from an OIT perspective, balancing privacy, security with retention. We've been engaging for the last 2 years, even prior to this particular situation, in what we would need to do to change our text platform to allow us retention. This report is not the first time we've thought about this and tried to move to this. The issue is finding a platform that OIT approves of that does not jeopardize veteran safety.
I think, as you might expect, I think my staff and I will have additional questions, perhaps in writing and maybe in a conversation. Dr. Miller, let me follow on a different topic. Within the John Q. Hannon Act, there's the Staff Sergeant Fox program. It seems to be overly administratively burdensome and has significant, what I would call excessive restrictions on the use of funding. Do you disagree with those broad conclusions, and what changes would you expect to make to alleviate the concerns that I'm raising or the concerns that have been raised to me?
Yeah, thank you, Senator. I appreciate that. We, as you are proud of the Fox Grant program. I do not disagree, however, with your statement. I think that this is a developmental process. This is the first time that we've engaged in grants, and we're learning to walk that fine line between too much and too little in terms of requirements and measurements. I think that there's at least 3 things that I'd be happy to talk with you at greater depth that we're learning along the way about walking that proverbial fine line, but we are committed to learning, growing, adapting as we move forward.
There's a lot of things that are really pleasing to me in this legislation, and this grant program is one of them that I think gives an opportunity for community and personal engagement in veterans' lives that I think is really, really important. And I want to see it succeed. And if there's something, I would like to have the conversation, but also if there's something that is missing legislatively, congressionally, please make sure that I know that.
I appreciate that. We will do so, sir.
Thank you.
Senator Hassan.
Thank you, Mr. Chair and Ranking Member Moran for the hearing, and Dr. Miller and Ms. Black, thank you as well for being here. I was really glad to see that the VA has chosen a week next month, October 16th to 20th, to designate as the first official Buddy Check Week in which veterans conduct peer-to-peer wellness checks. As you know, Senator Ernst and I introduced and passed into law the bill to make this happen. Our bipartisan legislation required the VA to build on what the American Legion had already started with the Buddy Check Week by making it a nationwide VA initiative. Can you talk about how the VA plans on conducting outreach to maximize the impact of the first nationwide VA Buddy Check Week?
Yes, thank you for the question. We're really looking forward to the first Buddy Check Week. That is scheduled for 16 October to initiate. We're also hoping to and targeting pairing the release of our annual report with the initiation of Buddy Check Week as a call to action. We are currently engaged in the process of talking with our close partners, the VSOs, regarding Buddy Check Week and implementation. One of the biggest concerns that we have with implementation is making sure veterans feel equipped to engage in it constructively and helpfully. We've completed training, therefore, for Buddy Check Week, and we'll be rolling that out within the next week.
Great, thank you for that. I wanted to follow on Senator Murray's lead to talk a little bit about women's veterans right now. Women veterans face unique hurdles to accessing VA health care and benefits, even though more than 30% of new VA health care users are women, and there has been a threefold increase in the number of women veterans accessing VA mental health services since 2005. So I want to help raise awareness among women veterans about the Women's Veterans Network, or WOVEN, program, which aims to develop peer support networks that are specific to the unique needs of this growing population of women veterans. What steps has the VA taken to address the unique mental health challenges that women veterans face, and how has the WOVEN program been developed to help improve outcomes for the women who participate in it?
Yeah, thanks for that question. Thanks for highlighting this as an example of an important program for women veterans. I agree with you. It absolutely is. What we are doing at the outset in terms of broad messaging is talking about the point that you made, that women veterans have unique risk factors. They have unique protective factors, and we need to be able to address those in a tailored way. In terms of WOVEN, pardon me, in terms of WOVEN, we've made some significant, I think, program evaluation observations and adjustments after the initial implementation. I think 2 examples serve as important to know for that. Number 1, we've developed a Train the Trainer program. Number 2, we've learned that we can go from a co-lead paradigm to a single individual leading. These two lessons learned and the implementation plan will exponentially increase in the next year our ability to implement more of these groups and opportunities.
Okay, that would be really excellent. One of the things I continue to hear, especially in rural areas in New Hampshire, from women veterans is how hard it is for them to know where the other women veterans are and to provide the kind of peer-to-peer support that's so important. So I'd look forward to continuing to work with you on that. Last question is about something I worked with Senator Kramer on, the bipartisan and bicameral push to enact the Solid Start program. That directs the VA, as you know, to contact every veteran at least 3 times by phone in the first year after they leave active duty service to check in and help connect them to the VA programs and benefits that they've earned and deserve. Last month alone, the VA contacted 23,479 veterans through the Solid Start program. How does the VA tailor outreach through the Solid Start program to veterans with mental health care concerns? And what have you done to ensure that those mental health concerns are being addressed as quickly and effectively as possible?
Great question. Not to be punny, but VBA is taking the lead on doing solid work in this. I defer to Dr. Black.
Yeah.
Yes, and thank you for that question. So when you look at the Solid Start program, that is one of the primary focuses, is ensuring that when we're making those contact with the veteran,
Right.
that we are asking those questions. So all of our Solid Start representatives, they are trained in suicide prevention awareness.
Yeah.
So when they're on those calls, that is one of the topics that is discussed. That is the topics that discussed. And not only that, our Solid Start makes a priority for any veteran who was seen in mental health the year prior to separating from the service. We make that a priority, and we engage those individuals as far as suicide prevention and mental health topics. About 80% of those priority veterans, we have made those successful connections with. So that is definitely a priority.
Okay, that's really, really helpful, because obviously if they had had a mental health consult or issue during service, the confusion or unease during transition, which is just, from what veterans tell me, can be a pretty confusing time, makes them even that much more vulnerable, right?
Yes, and ensuring that we make that warm handoff from care to care is vital.
Excellent. Well, thank you, Dr. Black and Dr. Miller.
Dr. Cassidy.
Hello. This is an incredibly damning OIG report. Incredibly damning. And I'm struck that the executive director, who apparently interfered with the OIG report, was not fired. She's reassigned, I presume still getting a paycheck, I assume still building a pension, having demonstrated her lack of truthfulness in conversation with the OIG. I'm told that the Director of Quality and Training, or Training and Quality, is in the same position as this person was before. Now, we've passed accountability measures for people who don't do their job. And it sounds like interfering with an investigation of a suicide, which may have been inappropriately handled on a veterans crisis line, is incompetence. So it may be a decision above your pay grade, but can you tell us why the only accountability that has been had so far is that somebody moved over to the Secretary's office?
Dr. Cassidy, we agree 100% with the necessity of accountability and holding our staff and team members to the highest level of standards when it comes to serving our veterans. The executive director that you mentioned is not named in interference, to use the term that you used. The individual who was listed as Director of Quality is discussed in that. The information that we had to that effect is new from the OIG evaluation and their review. It's not uncommon to receive new information.
I mean, well, then maybe the executive director, I'm quoting, reported that after completion of a quality assurance review, it was decided there was, quote, insufficient information for us to really move forward on a root cause analysis. However, leaders initiated the root cause analysis after the OIG notification of the inspection, although the text conversation had not been obtained. Now, it sounds like somebody was asleep at the wheel, and the question is, was it just incompetence or was it just a cover-up? So is anything being done about it? What is this person earning? Are they earning less than they were before?
No, sir, what you're referring to is an RCA in the context of reviewing the text exchange. This gets to the text retention issue.
Stop. I'm not asking text retention. I'm asking, were the people responsible for the failure of this system and who did not initiate the appropriate follow-up and are apparently tampered with people, responder number one, said things which may have influenced the way they responded to the OIG, how are they being held accountable?
They are under review using appropriate personnel, guidance, policy, and subject matter experts.
And the person who was transferred, did they get a cut in pay? Or are they making the same money or are they making more?
I'm not aware of a person transferred, sir.
I thought somebody was transferred to the secretary's office out of the position they had. Am I right on that? That is correct. I'm told that is correct.
There is an individual who took a different job. There was not an individual that was transferred.
Okay, took a different job. Just voluntarily took it and everybody said incredibly well qualified, no stains upon the record?
I can't speak to the hiring process that was engaged, sir.
And when did the process of review begin for each of these two individuals?
The process of review began for the first situation with responder one that's mentioned in the report immediately. The process of review.
And I'm sorry, what is the date on that?
The date would be November of.
I'm sorry, and I don't mean of the root cause analysis.
Oh.
I mean of the apparent attempt to influence how the OIG was spoken with.
Right. We did not become aware of that till OIG gave us feedback to that effect, which was about a year after the.
And how long ago was that?
That would have been in the spring of 2021.
And so the spring of 2021, and so
22.
the person's been, 22, has been under review since then. Has anything resulted from that review?
That's different, sir. You're talking about the review with regard to responder one.
Mr. Miller, I feel like you know what I'm asking, but you're deliberately dodging the question. I want to know, when did the review begin of the two people whom this report alleges interfered with the investigation and are told folks how to respond differently than what apparently was the truth?
The answers to your question, sir, require technical responses.
Okay, but tell me what day, what month did those investigations of those two people begin by the VA?
The investigation with responder one initiated.
And again, I'm not speaking of the fact that the veteran died. I'm speaking of the fact that the supervisor apparently, shall we say, misbehaved. When did the supervisor's misbehavior begin to be investigated?
That began when we learned of.
And what was the date of that?
The draft report was received by the OIG, I want to say maybe 2-3 months ago. That's when we first came to the information.
And so how
about
long will this investigation take to hold them accountable if indeed the OIG is correct that their actions were as you described?
I can't answer that question for you.
That veteran was ill-served, and there, as best as I can tell, an attempt not to hold people accountable. And my gosh, that is a pattern. Thank you.
Thank you, Senator. There is no doubt your line of questioning is appropriate, and your disgust with the situation is entirely appropriate. I think that we demand excellence from the people in the VA, and people need to be held accountable. And we're going to ensure that I'm going to be following up with the IG on this issue tomorrow, and I'll download with you from his perspective. With that, Senator Hirono.
Thank you, Mr. Chairman. I noted that Senator Murray, my colleague, mentioned the high incidence of military sexual trauma experienced, particularly by women. Dr. Miller, would you consider that a factor, experiencing sexual trauma in the military, a factor in suicide?
Absolutely. It's a risk factor, yes.
So I would say that as I read your testimony and you note these various risk factors, I would suggest to you that you include sexual military trauma in this list that you have. I think that's really important to call it out because of the high incidence of women who experience MST. So in noting the number of, by the way, would you start doing that as you prepare testimony for these kinds of hearings?
You're referring to the written
Well,
testimony?
that you should put in that military sexual trauma is a factor
Yes.
in suicide. So when we look at the numbers that you noted in 2020, that seems to be the most recent numbers we have. I hope those numbers are relatively accurate and not vastly undercounted, but 6,146 were veterans who committed suicide. Do you know how many of this number were women?
Yes,
Suicide?
that's available within our report.
What is it?
Off the top of my head, I'm sorry, I don't know. It is by count much lower than men. It is by rate rising and higher.
I think that's what should concern us because as more and more women enter the service, that their suicide numbers sadly are going up. And do you know how many of these suicides was associated with opioids?
In terms of opioid overdose or
yes, we can start
prescribing?
with that, opioid overdoses.
Yeah, we do have a report that's available for opioid deaths overdose that's separate from suicide reporting.
Oh. Thank you. So what would that number be?
That is a report that's generated by the Substance Use Disorder Program Office within the Office of Mental Health. There's also a publication from 2019 that updates that information, but we can take that back.
Would you say that that is a significant number of opioid overdoses that involve veterans?
Yes, that is a significant issue.
So thank you for telling us that opioid overdoses are not counted as suicides, because I think that it would be enlightening. I would have thought that it would be part of that information.
May I add one caveat to that?
Yes.
It depends on what the medical examiner puts on the death certificate. If the opioid overdose is viewed as an accident, it's not a suicide.
I understand. I do have a question about some of the categories or some specific populations that have a higher incidence of suicides. And in one of your reports, I noted that the rate of suicides among Asian American, Native Hawaiian, and Pacific Islander veterans is higher. And as a part of a response to a question that I had asked of Secretary McDonough, he noted that there were demonstration projects related to tailored mental health outreach for specified veteran populations, including AANH veterans and women veterans. So can you describe what you would consider a tailored outreach for women veterans and a tailored outreach for AANH-PI veterans?
Yes, we've been working on this and happy to talk about it. We've developed a partnership with the Rocky Mountain MIRIC to study suicide prevention in this particular area and specifically dedicated upon it. One publication has thus far emerged from that on geospatial considerations and how it impacts our knowledge of this population and in turn our programs, and they are currently in active recruitment for individuals to participate in the next phase of research. Simultaneously, we spent a couple weeks this summer traveling to Guam and to the Mariana Islands to talk firsthand with important points of contact there, including Governor's Challenge teams.
You're telling me then that you are specifically focusing on certain ideations relating to AA and HPI veterans.
Yes.
I'd like to find out more about what you are doing, what you're learning, and whether that informs some of the resources that you are providing toward outreach to these populations.
Yes.
And I'm particularly interested also in your outreach to women veterans. Thank you, Mr. Chairman.
Senator Blackburn.
Thank you, Mr. Chairman, and thank you for being here. This is an area that we all have concerns about in Tennessee with our clinics, with our large veterans population that is there. We do hear a good bit about this. I want to ask you all this. If I were a veteran in crisis and I reached out on the 988 right now and asked to be seen by the VA, how long would my wait be?
So I want to give you a technical answer, but you don't want a technical answer. The real answer to that is it depends on the local facility that you would be referred to
Okay.
through the SPC.
All right, I pulled some numbers. Out of our region, 32 of the 33 VAs in our region, the wait time would be longer than a week. And the reason I looked at that is because we looked at the National Library of Medicine study that goes in and they do the surveys on those that are hospitalized because they attempted suicide. It did not succeed. 48% of them said within 10 minutes from the time they thought about it to the time they made the attempt.
Yep.
That was the amount of lapse time. Now, if you want to look at some of these numbers, and this is what startled me, because these are individuals that are in crisis. We, as a nation, a government, have promised these veterans health care. And then if you look at the one of the clinics in Nashville, it's a 7-day wait. The Alvin C. York Veterans Hospital over in Murfreesboro, 8 days, 66 days at the Cookville Clinic. Dr. Black, you've been to UT, you know where that clinic is. And, you know, the Chattanooga Clinic, 71 days. Campbell County Clinic, 96 days. So this access issue is one that we've got to solve. I want to switch topics to an IG report on a patient's suicide following mismanagement of the Veterans Crisis Line. And it was on the 14th of September. I found it interesting that the director of the Veterans Crisis Line did not define the patient's death as a sentinel event. So what is the VA definition of a sentinel event? Because I would think that mismanagement and that death would be classified as a sentinel event.
Yeah. According to policy, and I feel badly talking about policy and technical things in the context of a veteran who's not with us and died by suicide. According to policy, a sentinel event is defined as a death or near death and can be reasonably associated with, from a causal perspective, to action or non-action on the part of last contact.
But he took his life within 30 minutes of speaking to somebody on that line. Mm-hmm. And if someone were to text, how long does it take you to respond? What's the amount of time on the text? When
Our response, if someone texts us, is immediate.
Immediate?
Yes. Now, the individual that we're texting with, it's not uncommon that their response is not immediate. There could be 15, there could be 20 minutes lag.
Do they ever call that number that they're getting the text from to try to make that personal contact? Or do they just sit there and text it?
Yes, our policy is that if the risk assessment indicates, we need to switch them to phone from text. And that was
Okay.
that was one of the things that we did wrong in this
Okay.
situation.
I do have some additional questions. My time is running out, but I'm wanting to look at your staffing levels. I'll submit this to each of you for writing, and the way that you are utilizing community care to help ease the burden on that staffing. I also want to know what kind of training you're doing to individuals that are crisis line responders, what kind of training that they're receiving. Thank you, Mr. Chairman.
So Senator Blackburn will put them in for the record and get a response for those, so thank you. Senator Blumenthal.
Thanks, Mr. Chairman. I want to just return to the exchange you had with Senator Hirono on drug overdoses. Those are not counted as suicide?
Drug overdoses that the coroner or the medical examiner determines on the death certificate are accidental, are not the official CDC definition of suicide, so they're not coded as a suicide. Those do not come to us for the suicide report.
So it depends on the local coroner?
Yes.
So the definition that you gave me earlier, or you gave to Senator Blackburn, or you gave us earlier, about, in effect, the causal link, how does that factor into what you count as a suicide by overdose?
Yeah, that's getting into a question that's more in the area of the medical or examiner or the coroner. Usually and very generally speaking, there needs to be indication of motive. Motive can be indicated by the means. Motive can be indicated by a letter or artifacts left behind as two examples.
I think what you're telling us is that the numbers of suicide may in fact be far greater than what you have tabulated and what you've given to Congress year after year, because this local coroner, I mean, I'm a former state official. Lots of coroners have different definitions, different way of applying that, what you called a technical definition. And I'm a lawyer, but I can't repeat the way you put it. Essentially, it's causal connection. And I don't know how a coroner makes that determination, which then determines the VA's reporting to the United States Congress. I think those numbers are probably tremendously incomplete. Let me ask you a more general question. You know, quoting you, suicide is a complex problem with a multifaceted interweaving of potential contributing factors. That's true. Would you say that we've really made significant progress over the last 10 years?
I think there's two areas that my mind would go to answer that question. The two questions, really. Have we advanced on understanding and treating or improving the why? And have we advanced on improving the how?
Well, have we advanced on the numbers?
We have not advanced.
We have not advanced on the numbers. So I don't know how you could tell me we've made progress on this problem. If the same numbers are dying, if the rate of suicide is 1 in 17, 1 in 20, 1 in 21, I don't even know the most current figure. Probably depends on the numbers of veterans, not the numbers of suicides, but the numbers of suicides are basically unchanged. How could you tell us that we've made progress?
Because we've seen certain areas of higher risk or risk where we have seen improvements and decreases. For example, veterans who are in VHA care and diagnosed with PTSD, there's been a 30% reduction in suicide rate over the last 20 years. Veterans in VHA care diagnosed with a depressive disorder, there's been a greater than 20% reduction.
Well, those are veterans in VHA care.
And
What
veterans,
about the total number?
and veterans not
I think
in-
our nation is judged not by the numbers who are in VHA care. They're bound to be lower. I would hope they'd be lower. But the numbers overall, if you were judging our nation, those numbers are unchanged. I mean, I think we need to face the fact, and I'm encountering constituents every day who say, why can't we make progress?
My answer to that, sir?
Yes,
It's
sir.
the how. 70% of veterans die by firearms. That is the number that hasn't changed and has only gone up. And until we make a significant improvement in that area, we probably will not see a significant decrease in veteran suicide.
So my time is expiring, but have you advised the leadership of the VA that it should issue a warning to veterans and their families that firearms should be removed from their homes and they should support red flag statutes and emergency risk protection orders in states where they are not now? And I've been probably one of the leading advocates in the Senate for separating people from guns when they say they're going to kill themselves or kill others. Shouldn't the VA be much more aggressive in advocating for those statutes?
We provide technical consultation on everything that comes our way from you and back up through the chain. I just flew here from Denver, where I was partnered with someone from your state, sir, and the president of NSSF to address firearm manufacturing industry regarding what we can do together and collaboratively to message exactly what you're saying.
My time has expired. Thank you,
Yeah.
Mr. Chairman.
Thank you. Before I get to Senator Tillis, I would just say that I believe you're on Armed Services. I think Senator King's on Armed Services, and Senator King knows this because we've talked about it. The transition between active military and VA, we need to do some work on, because I really think that's a huge driver for the suicides. Senator Tillis.
Yeah, starting with the fact that 2/3 of those who are taking their lives every day are not connected to the VA. We got to figure out a way to get them better connected. Dr. Miller and Dr. Black, thank you both for being here. You know, the exchange that you had with Senator Cassidy about maybe a mistake, it may very well be that somebody who was in a position to where they could have gotten a consult done, intervened, saved a life, but it could have also and more likely be related to a breakdown of a process and staffing, a number of other things. I just can't imagine somebody working that position would actually not care about trying to save that veteran's life. Exactly. But it is what it is. And to the extent that they failed to follow processes, they obviously need to be disciplined. Yes, I just believe in my heart of hearts it's got to be something more fundamental. OIG analyzed, an analysis of consults for PTSD, military sexual trauma, couples therapy, submitted from November 1st, 2020 through June 2022. They found 39.3% of psychotherapy, 39.5% of PTSD, 27% of military sexual assault, and 67, almost 68% of couples therapy consults did not meet the required time of 30 days from the patient indicated date. This sounds to me like and I guess as a part of the OIG report, they said it looked like staffing issues, backlogs, the clinical resource hub no longer available due to hub staffing concerns. Do you agree with the OIG's assessment or the information they received from mental health leaders that you do have staffing backlog issues that are a problem? And if you do, how are they being addressed?
Yes, sir. To answer your question accurately, to make sure I'm thinking of the same OIG
Yep.
report, are you referring to the one from North Carolina and Asheville?
Yes.
Yes. Okay. Yes, I from my review of what I know of that OIG report, there was concurrence to all the recommendations that were provided. I also believe that if we were to look at it today, that facility has made some meaningful progress regarding mental health hiring. I do know that the chief of mental health is today sitting at a training program for BHIP, which was also mentioned in that particular report. So they're making advancements on that as well.
Just moving on to other information that was included in the OIG report. One thing that stuck out at me is, look, I know I talk with a lot of veterans. I talk with a lot of veteran service organizations, and they all like the brick and mortar presence of the VA. Yeah. But when they can get an appointment and when they can get the care they need. In the behavioral health space, we do not have enough in the VA or in the general community, the general population. But can you speak to some of the passages in the OIG report that said that people within the VA were really discouraging community care referrals for behavioral health? Why they would do that?
So I think that from that and specific to the situation, from my understanding of it, there were discussions about exactly what we've said in here, which is VA care works, and let's capture as much of that as we can through appropriate mental health staffing. I think that there may have been interpretations of that led to then believing that it was a black and white and then discouraging community referrals. I believe in response to that OIG, the facility attempted to clarify that, and one of the recommendations that they are engaging is staff-wide training on that very issue, sir.
Yeah, I think it's critically important.
Yeah.
But for anyone in the VA, and I am a big supporter of the VA. I like to think of myself as a cheerleader. I very seldom flog y'all in these open hearings, but very seldom. But for something like this, we've got to have balance. This is about providing care. Mm-hmm. And unless you think you're knowingly providing a community care referral to somebody who's not competent to provide the care, refer the case.
Yes.
And then build a capability and serve more within the VA. But particularly in behavioral health crisis situations, days and minutes matter.
Yes.
And I think that anyone who in the VA is guilty of saying, well, you know, we just need to keep them in the mix, few more days, few more weeks. First, you're playing potentially with somebody's life. And the person who's saying that is running counter to what I've heard from everybody in the VA. Get the care, quality care as quickly as possible, in the VA if possible, but in the community when necessary.
That's all that matters. I agree with you 100%. You would know this better than I do, sir, but I believe specific to that region and your constituents, community care, mental health care is in short supply. It seems difficult to come by.
It is, and that's why we're, and Mr. Chair, I just want to mention this for future consideration. I met with Secretary McDonough when he was in Charlotte about a month ago. And I was talking to him about the Bipartisan Safer Communities Act. It made me think about it with Senator Blumenthal spoke up. That is one of the single largest investments in behavioral health that the Congress has made in modern history. One of the things I asked Secretary McDonough is, have we tuned it right to where, if you think about eastern North Carolina, think about between Fort Bragg and Camp Lejeune. Mm-hmm. Is there some place down there where maybe we have something that we haven't had before, collaboration with the VA, collaboration with the Army, collaboration with the private sector to stand up a behavioral health capability that doesn't really exist at scale down in that area? So I'd like for us, if we could, I've talked to Dennis about it, but I'd like to see if the plain text as we passed it facilitates that sort of thinking, or if we need to open it up and potentially consider that in areas where I think it could be helpful.
And improve telehealth in those areas
Yeah.
too, sir.
Thank you.
Yes.
Thank you, Mr. Chair.
Senator King.
Thank you, Mr. Chairman. Dr. Miller, nice to see you in person. We talked last week. One of the main issues that seems to be motivating suicides is financial and financial distress. And I think the data is 4 times veterans with incomes below $50,000 who have financial problems are 4 times as likely to have ideation of suicide. What about a pilot in the helpline of the crisis line of having some financial expertise that could be referred? Are you having a financial problem? Here's somebody you can talk to.
Yeah.
Is that something we could work on?
Yes, is the short answer. What you're getting at, though, sir, is an important point in terms of instead of having maybe the referral from the Veterans Crisis Line go to mental health, maybe it would be more appropriate for it to go to a financial counselor, in which case then there's a ripple effect in capacity with mental health. You save by putting people in the right place at the right time. Yes.
So is this something that you don't need legislation? Is this something you could pilot for in one vision, for example?
Yes, what we can pilot is we're starting a new Veterans Center for Financial Empowerment. That center will offer through VBA and services that are available with VBA referral to free consultation for financial issues. That'll allow us to get some initial data on demand and need and be able to report that back to you for next steps.
I'd appreciate it. I think that's an important step. Let's see what the data shows us, because it does appear to be one of the causation factors. Workforce. It seems like every hearing that we're at, we talk about workforce. And I keep hearing about the difficulty of onboarding people. For example, you want to bring on a new therapist. It may be a therapist, it may be a clinical social worker, it may be a psychologist. You got to do three different job descriptions and go through a long process. And in fact, I've heard of mental health directors who are spending 20 hours a week on administrative functions of onboarding people. How do we crack that problem? It just seems to be a problem throughout the agency.
Yeah, I feel your pain and theirs. We hired 900 Veterans Crisis Line responders in the last year and a half, and a significant portion of my time is paperwork to help move those issues and hirings along. I think that we're taking a good step in this area through the Undersecretary's initiatives that are informally called Tiger Teams. There's at least 6 key areas. Suicide prevention is one, but another one is hiring and retention and workforce management optimization. Watching how that group is able to progress with the targeted goals and outcomes will be important.
Well, I would hope something, and this isn't for you necessarily, but for the VA generally, instead of this iron hand of control from Washington, why shouldn't the local VA facility be able to hire the people they need? Washington can give them guidelines. Here are the standards. Here are the minimum standards, and those kinds of things. But somebody in Maine, if they need somebody, they ought to be able to reach out into the community and try to find them, and not go through all the steps that appear to be in this process. I don't expect you to answer that, but I think that's something, Mr. Chairman, we ought to talk to the agency about. I keep hearing about the administrative burden of bringing people on board, and then we need them. Final question. I think it was the chairman who used the term "better connected" about getting people connected into the system. One of the ideas that I'm working on is that a active duty service member can pre-enroll in the VA while still in active duty as part of the TAP process. Do you have a reaction to that?
Yes, I think that would, personally, I think that would be extremely helpful in terms of streamlining the process. Currently, what can be done is a transitioning service member can pre-register. They cannot pre-enroll. The reason why they cannot pre-enroll is because by law, they have to be a veteran by the legal definition of veteran to enroll.
Fortunately, laws are the business that we're in here.
Yes, sir.
Great. Well, I think that's something I'd like to see us work on. Thank you, Mr. Chairman.
Senator Bozeman.
Thank you, Mr. Chairman, and thank you and Senator Moran for having such an important hearing. And yeah, we have all the rancor that's going on around here, but this committee really does work in a very, very bipartisan way. And because of that, in the last couple Congresses, has gotten an awful lot done. We all know that suicide is really complex. It's a complicated crisis. There's no single solution. We also know that if people are in the VA system, they're less likely to commit suicide. Most of the people that are committing suicide are outside of the system. So one of the things that we've worked on, and most of the committee's worked on, is trying to make it such that we could capture those folks that are outside of the system, get them some help in the community, and then ultimately bring them into the VA where they can get even additional help. Mm-hmm. Dr. Miller, I appreciate you highlighting the Staff Sergeant Parker Gordon Fox Suicide Grant Program in your testimony. When we wrote the grant program, we intended to provide federal resources to organizations in the community that coordinate suicide prevention services outside of a clinical setting. Mm-hmm. I have met with many grant recipients and heard incredibly positive feedback on the program. After 1 year of this program being in effect, what are the biggest lessons that you've learned? And have you identified ways to improve for the future? So this has been going on for a while. You know, you've got these grant programs out there. What are you finding with them?
Yeah, I think one thing that we're learning is it's written into the law the importance of screening for risk and ensuring that the services are going to those who are at higher risk. But we're learning as part of that process that one of the many beauties of this grant is the services that a lot of the grantees are providing are what we may call upstream in nature. So it's a bit contradictory for them to be necessarily screening for risk and screening out those who aren't high risk when a lot of the work they're doing is moving upstream before these individuals become high risk. So resolving that, I think, discrepancy, I think, is a challenge for us that we're committed to working with you and this committee together. I think the second thing I would say is we're learning a lot about how to screen for risk in ways when you're not a licensed mental health professional and it just feels out of your normal flow of what you do to pull out a survey, a questionnaire, and say, I have some questions here that I need to ask you. So I think we're taking a close look at the screener tool that we've implemented as part of this and wanting to take a look at, is there a better way to meet the requirements of the screen without necessarily asking grantees to slip into a role that feels very unnatural for them as part of their service.
Yeah, and this follows up on your comments and then comments that Senator Moran had, but it does appear that when you visit with people, you know, that are involved, that there's just something about government that makes things pretty complex. And I'm part of government, I understand that. But, you know, providing increased flexibility in that area and you know, the whole process, I think, would really be helpful. So
Absolutely. I think that would, I would want that to be an open discussion between us, because how I may define increased flexibility, I may have a blind spot then in terms of what you were intending with the law and the applications of the law. So I think it's really important we continue our open and collaborative dialogue so that we are fully capturing your intentions with the law.
no, I agree, and I think something would be helpful if we could discuss with you, but also get some providers in, you know, to help us realize some of the unintended consequences. We all want the same thing. That maybe, you know, a requirement or whatever just makes it a little bit more difficult. So
Yes. I'm looking forward to panel 2. I think it'll give us some good insights and steps forward.
thank you.
Thank you.
Well, thank you, Chairman Tester, for holding this hearing, and thank you to our panelists for being here and for the critical services you provide for America's veterans. I'll focus my questions on mental health resilience for veterans and for their community, but first I want to address a time-sensitive issue. Much of what we discussed today centers around access to care for veterans, and part of that access is transportation to the point of care, like a VA hospital or a clinic. The VA is currently implementing a rule that decreases veterans' access to ambulance services, particularly in rural parts of the country like northern Arizona. So I commend Senators Tester and Moran for their quick bipartisan work drafting and introducing the VA Emergency Transportation Access Act to address this issue, as well as a related amendment to the appropriations bill that I hope to vote on in the near future. I look forward to working with the committee and the VA to protect veterans' access to life-saving ambulance services. Since coming to the Senate, I've led bipartisan efforts to help service members and veterans build supportive, resilient communities. First, by earning broad support and passing my Sergeant Daniel Somers Veterans Network Act into law, and more recently, by introducing the Military Suicide Prevention in the 21st Century Act. As we know, networks of support for our veterans are vital to their well-being. So my first question is for you, Director Miller. National Community Health Partners, which is based in southern Arizona, has recently launched a project called The Best Is Yet to Come, funded through the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program, one of 3 such grantees in Arizona. Can you speak to the importance of these grants to community organizations?
Yeah, absolutely. I think that there's a few things that come together under the heading of our community-based suicide prevention plan that reinforce your points exactly. The community-based suicide prevention plan focuses on the fact that suicide prevention is not just clinical. It does not just occur in the room between a patient and provider. It occurs in the community. And as such, we have the Governor's Challenge. We have the development of community coalitions and collaborations, and then we have the Fox grants. Arizona is leaning forward in each of these areas. And what we've seen out of states like and such as Arizona is the importance of, at the state level, at the county level, forming veteran suicide prevention plans for the community that are informed and built by the community. And then we're able to come in and support through the Governor's Challenge. We're able to come in and support through the Fox grants. The fact that you see that with the Fox grants is evidence of the strength of that in Arizona.
Thank you. I still hear from my Veterans Advisory Committee in Arizona that the lack of a cohesive network creates challenges for veterans. So what additional resources do veterans have to find a community after their service?
I think that that's a critically important consideration, because one thing that we know, and I think we're going to see this more and more in the data, there's a relationship between connection, lack of connection, and suicide, particularly for veterans. So in terms of creating a community, I think one important step is the solid start. To that, I'll defer to Dr. Black.
And thank you, Senator. Yes, the Solid Start program is that first critical year after separation from the military. So those calls at 90, 180, and 365 days. It's helping to connect to the community. So when our solid stock representatives are making that call, that is some of those questions that's asked, and helping connect them to their local VSOs is one of the things that they'll do. If that is something that is an issue for the veteran, it is based, those calls are based on the veteran needs. So if they're saying, yes, I'm having a hard time, finding community connections, that's something that'll be addressed in those calls.
And are there any metrics that we can use to gauge the growth and strength of these types of support networks?
I think that the metrics that are associated, the first thing that comes to mind is the metrics that are associated with the Governor's Challenge and the work that we're doing there. So the practical application of that would be, what is Arizona seeing in terms of the number of community collaborations that have been built, implemented, maintained? That would be an important indicator. Nationwide, we just reached 1,500. How is that relative in Arizona? Is it growing? What lessons are we learning?
I see my time's expired. Thank you, Mr. Chairman, for holding this hearing on such an important topic.
Thank you, Senator Sinema. You heard my opening statement, and I think you're fully aware that 60% of the veterans who commit suicide don't have any engagement with the VA. Senator King has a bill that will enroll the service member before they get out of the service in the VA. I want your opinion. Is that a solution?
So there's the answer that I could give, which is we will review that through our technical consultation team and experts, and we would
Except I want your opinion.
My opinion is that when you look at engaging pre-registration and the percent that we are able to do with that, and then you look at how that converts to enrollment, there's a gap. So the short answer is, if you can cut that gap down between pre-registration and enrollment and make it all the same, that just makes sense to me, but that's just Matt Miller talking.
Well, that's right in front of this committee, though, okay? If you were a nobody, you wouldn't be here, all right? So, Dr. Miller, the Strong Veterans Act included silent monitoring requirements of the Veterans Crisis Lines.
Yes.
The IG was critical of that, too, in his report. What assurances can the VA provide to this committee that Veterans Crisis Line responders are receiving the appropriate amount of silent monitoring today?
Yeah, a few things, and I think that's really important because that's one of the keys to rebuilding trust, I think, in this situation. Number one, if you look at our staffing levels in January of 21, when this tragedy occurred, we were about 550 responders. We have since added 900 plus responders. Why does that matter? That matters because the context of this situation is we were using someone in an overtime role who wasn't regularly a responder. My point is, we don't have to do that anymore to answer any call. So that's one step that's been necessary here. The second step is 2 forms of silent monitoring that must occur on a monthly basis and be reported. 90% supervision or supervisor performance monitoring, 80% silent monitoring. We report that on a monthly basis, as I said, and as part of the OIG recommendations, we're going to be reporting that and our progress to OIG. We will not be able to close that recommendation until we reach a level that they're satisfied with. That said, I know for a fact, because I looked at it today, we're at over 90% for both the supervision silent monitoring and the silent monitor silent monitoring. Okay. 2 forms.
All right, you answered my second question with that answer. So in the Section 701 of the Hannon Act, and by the way, this law was passed, was signed into law in 2020, it implements new telehealth access grants. The VA doesn't expect to be able to give awards out till 2025. Not to beat this, but 2020 is when it was signed into law. We're not going to get any grants out till 2025. Telehealth's really important in a rural state. I think it's important in an urban state too, quite frankly. What can you guys do to expedite that rollout, or are you happy with that timeline?
We're not happy with that timeline.
Okay.
I think that in talking to those who are leading this particular effort, my understanding and perception is that we are not happy. We have looked at options to expedite. There has been some consultation that's needed to occur with OGC, and OGC has found themselves needing to fill in some details towards enactment, and the impression that I got in talking with them is it's better to measure twice, cut once, than to do it wrongly legally.
I got it.
11 months.
Yeah.
That's a standard.
That's a very good point, Senator King. I would also point out that if it takes us 5 years to do a telehealth grant, get them out the door, we got no hope to ever get electronic medical records done. We just got no hope.
We were, I think, very quick and efficient with Staff Sergeant Parker Gordon Fox, so I think there's hope.
Okay. Last question, because we've got another panel, although I will defer to the ranking member if he has another question, and maybe even to Senator King, but it better be a damn good one. Recently, we introduced a bipartisan, not just a number act. Senator Bozeman was just here. We introduced it together. Requires the VA to examine the association between veterans' use of VA benefits and suicide. I think you could also bring in the point that Senator King talked about financial difficulties. Dr. Merrill, how could outreach to an analysis of veterans who use VBA programs help? Do you think it would?
Let me give you.
Do you think it'd be worth the time spent to look at them?
Yes, sir. Let me give you an example to illustrate. Reach Vet is considered a leader nationwide and internationally in risk prediction for suicide. Reach Vet is based primarily on clinical factors pulled from the medical chart. We know that from looking at the data, the majority of veterans who die by suicide by firearm don't show up in the top 50% of risk for Reach Vet. They show up in other areas that are outside of the clinical. So then the short answer founded upon that is yes, sir.
Okay. Senator Moran.
Thank you, Chairman. I'll use my time with my opening statement that I didn't give to just ask a couple of clarifying questions. First of all, Senator Tillis and Asheville, your answer to him involved that, the question that I want to raise is about the lack of suggestion or recommendation or appointment to community care. And your answer was that we think that there was a policy in place that we were trying to keep our patients within the VA. We believe we provide better service. And you indicated, I think, Dr. Miller, that the Asheville staff was being retrained or trained to get this right. Did I make that up, or that's what you said?
I think the only thing that I would suggest modification on is I don't know that there was a policy in place. I think that there was a communication about the general spirit of VA provides great care, let's provide great care.
And the point that is what you said, and the point I want to make is that the directions, though, were given to the hospital at Asheville, not more broadly within the VA?
Yes, in this particular OIG.
Because the OIG pointed this out.
Yes.
I would say that it's happening across the country. That's not a policy, but this belief that the VA provides the best service, and therefore community care is often not suggested to a veteran. I hear about it consistently at home. I hear about it from my colleagues, and it's not what the Mission Act says. The issue there is that you can have community care if your wait time is too long or if it's in the best interest of the patient, the veteran, determined not by the VA, but by the veteran and his or her provider.
Yeah.
I'm restating what the law is, but it's not ever been clear to me that the VA is interested in making community care that widely available. And I think it's particularly important in this hearing, where mental health services are rare, hard to find within the VA and sometimes outside the VA. We don't have enough providers anyplace. But it's also important because it can be a life and death circumstance, and the failure to suggest community care is one of those life and death circumstances. It again, is not in compliance with the law as we wrote it. And I wish that your answer would have been the VA is now providing direction to all VAs, all VISNs, all hospitals, all providers, that community care is an option in the circumstance, particularly when a veteran cannot get an appointment within the VA. Let me ask a more technical question. I think you've said that if you're suggesting ideation of suicide, you can get an appointment within 24 hours. Did I hear that? Or is that true?
That's not what I meant to say in that particular context. What I think I was talking about was same-day access that any veteran should be able to request, and there should be an option for it at the VA facility or the community-based outpatient clinic. Now, with that said, yes, there should be immediate access for any veteran who is experiencing suicidal thoughts.
The point I want to try to make sure I understand is I think you said we could get an appointment within that time frame. And does get an appointment mean you are seen by a provider, or does get appointment mean you are scheduled to be seen by a provider?
No, in this case, in a crisis, if we're talking about, and we're not even talking about an appointment, let's say we're talking about an encounter, an engagement. You go and do the appointment after the fact just to make sure that it's logged into the system. That's what should occur with same-day access and with
Same-day access is different than getting an appointment. Same-day access is same-day access. Getting an appointment is something that's written on a piece of paper. And,
yes.
All right.
What you're highlighting is a nuance that I think is important, and that is that there are different dimensions of access. There's emergency access, there's routine first appointment, and there's follow-up episode of care. What we need to do in the VA is be carefully watching, providing for, and monitoring all three types of access.
You're talking VA healthcare broadly, or VA healthcare as it relates to mental health and suicide?
Well, I would argue broadly. However, mental health specifically is unique somewhat in that you commonly see the need for emergency, first appointment routine, follow-up for episode of care.
And now for my closing statement, Mr. President, Mr. Chairman, which was the opening statement. I had a veteran from Kansas visit my office this morning. This is her story. She shared that after the beginning of mental health treatment at a Kansas VA medical center, she was referred to a local vet center because of staffing shortages at the VA health center. When she reached out for an initial appointment with the counselor at the vet center, she was told their caseload was already full, and unless she was experiencing suicide ideation, they would not be able to prioritize her. 6 weeks later, the veteran received a follow-up call from the vet center saying, "We'll not be able to help you at all. We don't have the staff," I think was the point. That's now months ago, and she has had no follow-up, no effort to re-engage, never met with a counselor. And unfortunately, I don't think this is an isolated circumstance. And so this is an example. I mean, I heard this with Senator Murray and her conversations about the number of days. I heard it with Senator Blackwell and the number of days for care and treatment, for an appointment, for attention, and so the other point that I make is not one time, this veteran said, did she ever hear anything about the possibility of going to the community, because both the hospital and the vet center failed her for lack of capability of seeing her due to staffing shortages. It is why my support for community care is not at all based upon any bias against the VA. It is that too many veterans fall through the cracks when there is the reason that we created community care in the Mission Act was a result of their lack of capabilities of a hospital in Phoenix meeting the needs of our veterans. And so we gave initially choice and then the Mission Act, we gave an option to try to solve the staffing shortages. They still exist, and the law says a veteran is entitled to, in many circumstances, care in the community, but they don't know it if the VA doesn't tell them and if the VA doesn't make it available for them. What am I missing?
Nothing, sir. Message heard.
Thank you.
And that was at a C-Box in Wichita?
Was it a hospital in Kansas?
A VA hospital.
A VA hospital in Kansas.
Okay. Yeah. Look, thank you guys very, very much. I appreciate you being here, Dr. Miller. I wish to let Dr. Black speak more, but you did a fine job answering the questions, and we appreciate you both being here. I think, as the ranking member said to me a bit ago, we've had so damn many hearings on mental health, and it doesn't seem like anything has changed. And I know there's no doubt in my mind that you want to do the best for our veterans, and you're trying to do the best for your veterans. And this is really frustrating for me to say, but we got to do better. We just got to do better. This isn't saleable. It's keeping people out of our military when we need more people in our military. It's ruining lives. It's ruining families. And so we all need to work together to make sure this happens. And please know that this committee would probably give you anything you ask for when it comes to mental health. We just need to make sure that what you're asking for is something that actually will make a difference.
Mr. Chairman, the legislation that we're talking about, John Q. Hannon,
Yep.
is a result of your leadership. I chaired the committee when this legislation was passed. It was your piece of legislation named after a veteran in Montana.
That's correct.
This matters to you, it matters to me. And I want to be helpful to you. This committee does want to work together with the Department of Veterans Affairs to save lives.
Yep, amen. And so we're all on the same page here, okay? Thank you for your time. We're going to get the next panel going. Thank you. I'll start by welcoming our witnesses to the second panel. First up is going to be John Eaton, who is the Vice President of Complex Care at the Wounded Warrior Project. John, I will tell you, earlier today I got to meet with some women from the Wounded Warriors Project, and I will tell you that it was enlightening and beneficial for me, and I'm glad you sent them over if you did or somebody did, but it was a nice conversation. Then we're going to hear from Gilly Cantor. And I'm going to tell you, Gilly, you're the first Gilly I ever met, okay? And it's good to have you here. You are the Director of Evaluation and Capacity Building for the Daniello, better yet, Institute for Veterans and Military Families at a great university in New York, Syracuse, and it's good to have you here. I would ask you to keep your comments to 5 minutes. As of the previous panel, please know that your full written statement will be a part of the record. We will start with you, Mr. Eaton.
Thank you, Chairman Tester, Ranking Member Moran, and the distinguished committee members for this opportunity to speak. Since 2003, Wounded Warrior Project has been working to transform the way America's injured post-9/11 veterans are empowered, employed, and engaged in their communities. For the past 20 years, we've supported warriors through and beyond their transition to civilian life with services in mental health, physical health, peer connection, career counseling, and financial wellness. We currently offer these services to over 195,000 veterans across the country, and we're welcoming hundreds more every month. Our vision to foster the most successful, well-adjusted generation of wounded service members in our nation's history brings with it the responsibility to identify, address, and serve the mental health needs of the veterans who reach out for help. In our 2022 annual Warrior Survey, nearly all respondents reported experiencing post-traumatic stress, traumatic brain injury, or other mental health injuries during their military service. 83% reported experiencing more than one. Outreach and awareness building have been critical parts of our mission because, sadly, many veterans don't seek the help they need because of fear of being negatively labeled, or they don't know the programs and services that are available to them. Wounded Warrior Project is here to help them at no cost get the specific type of mental health help they need to take the next step on their journeys to recovery. Of course, we believe no single organization can meet the needs of our injured veterans. We also believe that evidence-based mental health treatment works when it's available and when it's pursued. However, the best results will be found when we embrace a public health approach focused on increasing resilience, improving psychological well-being, and building an aggressive prevention strategy. VA is our biggest and most important partner in that pursuit, and it's critical that we give them the tools they need to succeed. Our written statement outlines several ways that Congress can help, but this afternoon I'll focus on 5 important steps that this committee can take to help take the veterans suffering the invisible wounds related to their service of our nation. First, we have to reduce wait times for accessing mental health. VA's access standard is reasonable on paper, but the practical experience for many veterans who ultimately seek care through Wounded Warrior Project indicates that many of them are being offered appointments well beyond the target without any clear discussion with their provider about how care may be found more quickly in the community. In addition, the lack of a consistently applied access standard for residential rehabilitation care for mental health has essentially resulted in no true access standard for care. Fortunately, both the Making Community Care Work for Veterans Act and the Veterans Health Act offer solutions to both of these problems and improvements over the status quo. Second, we have to acknowledge and respond to the fact that access to care issues at VA are a symptom of a larger challenge of needing more mental health providers. Recent HHS research indicates that 164 million Americans live in areas with mental health professional shortages, and so it's no surprise that VA is facing several shortages in psychology, psychiatry, and social work in many of its facilities. To address these problems, we call on Congress to pass the VA Careers Act and the Mental Health Professionals Workforce Shortage Loan Repayment Act, the first of which would help VA recruit and retain more mental health providers, while the latter would address the fact that mental health isn't just a veteran problem, it's an American problem, and we simply need to get more providers in the field. Third, we should focus to continue encouraging VA to leverage telehealth as a means of making care more accessible. Veterans who share their stories with us through surveys and action often prefer telehealth for its convenience. However, those preferences should not be assumed, and veterans should be provided with clarity and transparency when telehealth is available as an alternative to in-person care. We believe that telehealth should satisfy access standards only when a veteran has agreed to it with a clear understanding of their options. Fourth, we continue to support investment in VA grants and partnerships within the community to provide upstream suicide prevention services. We remain hopeful that the Fox Grant program will become a permanent fixture in VA's public health strategy. However, we believe that attention should be given to how service eligibility determinations are made and how clinical care can be responsibly provided before the program is made permanent. Fifth, and finally, we encourage this committee to take care in understanding that brain health is not always synonymous with mental health, and that there are steps we can take to improve the quality of life to mitigate factors for suicide among those who have suffered traumatic brain injury. A growing body of research is showing greater association between TBI and suicide, and while TBI often co-occurs with a mental health diagnosis, we encourage stronger support in long-term care to address the care and financial stressors that can affect those with moderate to severe TBI. To that end, we urge Congress to pass the Elizabeth Dole Home Care Act and the Expanding Veterans Options for Long-Term Care Act, which would collectively serve the long-term needs of younger veterans who need this care earlier in life. In closing, I want to thank this committee for the invitation to testify and welcome your questions.
Thank you, Mr. Chairman, Ranking Member Moran, and members of the committee. Thank you for this opportunity to testify. I'm Gilly Cantor. I serve as the Director of Evaluation and Capacity Building at the Daniello Institute for Veterans and Military Families at Syracuse University. our contribution to this conversation is rooted in upstream approaches to suicide prevention. For 10 years, we've played a key role in building and evaluating networks of health and community-based social service organizations. Originally, those are part of our America Serves initiative, which is in 18 communities across the country. These collaborative models have demonstrated that helping veterans navigate to the full scope of services and resources they need beyond clinical interventions alone is an integral component of suicide prevention. At the same time, we have witnessed unprecedented effort from this committee and Congress and the VA to better integrate communities into suicide prevention strategies. It is the strong belief of the IVF and on behalf of our partners that we must not give up on the promise of these efforts, but rather ensure that they live up to their potential. So today, I'd like to reinforce why communities remain essential to effective suicide prevention, and I'd like to demonstrate that establishing transparency and accountability between the VA and communities at scale is both achievable and necessary. There are 3 findings I want to highlight from a study that we did with the VA Center for Health Equity Research and Promotion. We looked at collaboration between America Serves networks and VA medical centers in their communities. First, we found high overlap between America Serves and VA data, even in communities with low levels of partnership. In other words, many veterans enrolled at the VA are unquestionably also receiving services in their communities. Second, veterans served by both the VA and the community were comparatively younger. They included more Black, Hispanic, and women veterans, and they had more health-related social needs like housing and food insecurity. So in other words, communities are reaching the most marginalized veterans, experiencing the most hardship. And third, when partnerships were strong, veterans receiving health care from the VA and services in the community were more likely to have those needs successfully met. So when we work together, the stressors impacting veterans' well-being can be more effectively addressed. Broader research shows, and this was talked about earlier, that these economic, social, and interpersonal circumstances increase the risk of suicide. Imagine what more we could do if non-health data like this was examined regularly and shared. We must support legislation like the Not Just a Number Act and bring all the data the VA and communities have to bear on this issue. Additionally, we know from our own evaluation of America Serves in Pittsburgh that hundreds of veterans are formally referred between the VA and the community each year. Because this data is meticulously tracked, the VA has full access to this information. This level of transparency is also happening in other places, such as North Carolina and Texas, but it's not happening everywhere. Finally, I'd like to share opposing accounts we heard during our roundtable with 11 of our partners who are recipients of the Staff Sergeant Fox Suicide Prevention Grant Program. In one community, the suicide prevention coordinator sat shoulder to shoulder with the grantee. They streamlined enrollment into the VA for those who screened eligible due to the risk. In other communities, suicide prevention coordinators were hardly aware of the program, and the ability to facilitate that enrollment was not happening. We need to make these successful communities the rule and not the exception. We've submitted a full brief as a statement for the record on that roundtable and encourage the committee and the VA to consider its findings, and we're happy to talk about it as much as they'd like. If there's one message that I'd like to leave you with in light of some of the tragic things that have happened, again, focusing upstream, it is this. We think there's more to be hopeful about than there is to criticize. We are all here because the stakes remain high and the consequences of failure are quite literally existential. But we have collectively taken meaningful action and effective steps towards our shared goal. We simply need to monitor our progress and have the courage to adjust course along the way if necessary. Thank you.
I want to thank you both for your testimony, and I want to start by commending you both for the work that you and your organizations do. I will tell you I like the optimism of saying that we have more to be thankful for than we do to be critical of. You know, if this was an easy issue, we'd have had it settled a long, long time ago. The human mind is a hard thing to try to figure out how it works. And there's proof around this place all the time. So it's an interesting situation. I'm going to start with you, Mr. Eaton. As I indicated in my introduction of you this morning, some women from Wounded Warriors Project came to my office, and I talked about a lot of things, including a survey that Wounded Warriors Project just did about women veterans. Could you give me an idea on what that survey said about mental health? If it said, and I haven't had a chance to read the documents they gave me, okay? So, but if it said anything about mental health, could you talk about that? And if there are solutions, talk about those too.
Yes, thank you, Mr. Chairman, and thank you for meeting with the Women Warriors from Wounded Warrior Project. Just yesterday, we released the report, so the 2023 Women's Warrior Report, and it was based on surveys, as you mentioned, from 5,000 women warriors from our alumni, as well as in-person focus groups across the country to really collect qualitative and quantitative data. The findings crossed multiple areas, to name a few: access to care, transition from military to civilian life, as well as financial wellness. With respect to the mental health area, anxiety and depression were the top 2 health challenges reported by women warriors. And research shows that women are more likely to show moderate to severe symptoms, as well as PTSD symptoms, than our male warriors. Also, a higher percentage experienced loneliness and isolation compared to men as well, which is hugely detrimental, as we know and have discussed today, to our overall mental health. There is good news that came out, one of which women were found to score higher on resiliency measures, and 8 out of 10 women warriors reported have accessing professional help at least 12 times over the last year. So we're, as a population, very resilient and engaged in their mental health and wellness, which is a really good finding. And so what can we do? What we've taken away is really the opportunity to focus on transition and how do we ease the stress and foster better connections to other veterans and support networks after service, as well as making the VA a more desirable place for care by making it easier to access with appointment times and gender-specific care. And finally, additional research that can be done to understand the whys behind how men and women are experiencing trauma, and thus seeing the results on the survey.
Was there any sort of conversation around how well the VA is doing?
So that is a topic we discuss with veterans across all of our alumni, and over 90% of our alumni report using the VA for their services. When we think about access to care, we hear the same feedback from our female warriors as we do male warriors, and long wait times perhaps, and how that affects. It's really important when we're at the moment of readiness to really capture that momentum, and oftentimes without that, we're seeing poorer health outcomes, both mental, physical, family, and relational issues as well.
So, Gilly, this next question is for you. The Not Just a Number Act is a bill that we have with Senator Bozeman. I appreciate your mention of it, because I think suicide goes way beyond just mental health practices. This bill would also look at things like disability compensation, education, employment benefits, home loans, foreclosure assistance, housing assistance programs. From your seat, how could you, from your seat, tell me your analysis of veterans who use VBA programs and how this bill could improve VA suicide prevention efforts?
Sure. I don't know a lot about exact likelihoods or things like that, but I do know of a recent Brown University study that looked at Vietnam veterans specifically and their usage of disability compensation, and it was directly associated with certain improved health outcomes, which just tells you that there's a lot more to look at there. And I think that if we can't look at that data regularly, then we're doing something wrong. And I think that in order to make that possible, it wouldn't surprise me if there's sort of some underlying infrastructure problems technology-wise, and it gets into the weeds and it's boring data stuff, but I really think that part of it has to do with how different agencies, including within the VA, track data, and it doesn't line up. We've seen it between DOD and VA, it's even within VBA to VHA. It's really hard to match things up and to look at things really clearly and get an understanding of what's going on without taking years to do a research project, and that's a problem.
Okay. Thank you both very, very much. Senator Moran.
Senator King, I'd be happy if you'd like to go next. Let me start with you, Mr. Eaton. Thank you very much for being here today. Thank you for your work on behalf of Wounded Warriors Project. I appreciate very much your remarks in your testimony and your written testimony about the Veterans Health Act. It reflects an effort by Senator Senna and I on a topic that we've tried to be prevalent on and relevant on today. Could you discuss in detail, more detail, how the VA's current misinterpretation of access standards set forth in the Mission Act are having a consequence on veterans' access to care?
Yes, and thank you for the question. We discussed in our written statement, so the VA's Mission Act, standards that do not exist around the critical mental health rehabilitation programs. So instead, veterans and advocates are left to really interpret that VHA directive, and in our experience, it provides little predictability on acceptance of referrals, length till a decision, and other really important factors when we know that time is of the essence. What we're seeing in our C3, our Complex Case Coordination Program, works with the most in-need warriors who are experiencing mental health concerns, and oftentimes an RRTP is an indicator for their care. And so what we're seeing, though, local policy variations that are, again, unpredictable referrals, lengthy wait times, and really not a formally calculated way to be consistent about how we're understanding those options so we can advocate for the veteran. And what also comes as a result is that alternative treatment options that could result in a community referral or an inter-VA referral aren't taking place. And so, in totality, that really just shows that, what we're seeing is veterans are not accessing the care they need when they need it. And delays in finding that appropriate care really enable our opportunity to capitalize on the momentum and the willingness to get that treatment, which oftentimes is years in the making and really important.
I'm sure from time to time I'm told that the reason that the VA is not making referrals to community care is the lengthy
Wait times in the community. Is that anything that you hear? And what's the reality there when we know there are wait times also at the VA?
Sure, and that's a great point. I think as we talk about mental health shortage, it's obviously something that's not only seen within the VA, and so it's very regional specific, and that's why our team looks at all options. The primary, working with the VA within that program to establish their holistic care within that system of care. What I know is that we have a very cultivated group of partners from RRTP programs that are part of the community care network, and it would be our experience that we have very quick response times for when those needs arise. For example, we serve over 6,000 warriors a year with outpatient mental health services with wait times less than 14 days for a first appointment, and generally in most cases. And so I think depending on the region, it could be a better choice whether it's a VA or a community care network, but ultimately really feel the veteran should have more visibility into that conversation.
Thank you for that answer. Ms. Cantor, you, in your testimony, talk about the recent convening of 11 organizations who are Hannon-Fox grantees. This takes me back to my first question earlier. Would you elaborate on the need for the VA? You talk about the screening issues remain a barrier. Elaborate on the need or what the VA could do to open up the eligibility standards to meet the needs of veterans who we're trying to reach and better serve.
Sure. So one of the issues that came up was around who is eligible and then also on which services are eligible at which points. And I really appreciated how Dr. Miller described the tension that's going on between trying to get it to be the right people and the right things. And I think that what we're seeing and what the communities are saying is that depending on which screeners individuals screen for risk, some not others, and it depends on the person, that can cause people to screen ineligible. And so they're looking for more flexibility in which screeners they use, or the possibility of making sure that as long as they're screening on one, even if not the other, that constitutes enough of a risk for someone to get to be eligible to be enrolled. They're also hoping that they can increase which services are eligible for coverage under the program so that they can try to do better outreach and get more people in the door in the first place, access to transportation, being able to provide food, making it a more welcoming environment for people to come in and connect with others and address isolation and then hopefully ask for help.
Any ways for the screening to streamline the screening? Sure. and make it more friendly?
They expressed a need to make it more conversational. That was one thing that came up repeatedly, and that the forms that accompany the screeners that they have to fill out would also need to be tailored to accommodate that style, where right now it's difficult for them to do those intake screenings and then have to populate other things. And so there's sort of this extra barrier during the screening process just for them to make sure that those conversations, or Dr. Miller referred to this, trying to ensure that they're not clinical conversations, because the goal of this is to take the clinical element out and get more people, get more of the 10 people who die by suicide that are not connected to the VA, comfortable, screened, and connected.
Any suggestion that this help from these organizations that receive the Hannon Fox grants, that would help us get to those who are not engaged with the VA?
I think, this is me speaking, I think it would. I think that most of them, I mentioned the study we did, 70% of, this doesn't apply to all those partners, but for those that it does apply to, 70% of the people that are veterans that they work with showed up in VA data, but that means that 30% didn't. And that's just from the veterans. They also serve family members. They also serve caregivers, et cetera. So I see at least a 30% opportunity there for people that they're talking to every single day.
Ms. Cantor, I never thought about when we wrote the Hannon Act that these grants to community organizations might increase the population of who is served. But your testimony, your conversation with me, kind of a light bulb went off that I don't know whether it's true, but it sure seems kind of common sense to me that one way to serve more veterans, those veterans who are not engaged in the VA today, can be through a community organization.
Thank you for that comment. I fully agree.
Okay. Senator King.
I wanted to start with two general comments. Number one, you may wonder where everybody is. At this very moment, there is a classified all senators briefing on the conflict in Ukraine. And this is one of the most dedicated committees in the Senate, but I just want you to understand that sometimes we have these inevitable conflicts in terms of time. So that's where everybody is right now.
Senator King is pointing out that he and I are the most devoted veterans.
Yes. Yeah. Okay, second, in these hearings, we always are talking about how we can improve things, we can do better, and they often turn into somewhat negative about the VA. I think I can tell you from the point of view of what I hear from my veterans in Maine, they really like the care that they're getting from the VA. They are impressed by the personal qualities of the people that they meet with, and they get great care. Now, one of the issues is access. The question is, when do you get the care? And that's a larger issue. We've got an enormous shortage in this country of mental health professionals. In fact, we've got an enormous shortage of just about everything. One of our major hospitals just told me recently they're short 800 nurses. I mean, that's what we're up against. So I think we need to understand that it's not for lack of trying that the VA is short-staffed. This is a nationwide problem in and around the VA, but just generally. So the question is, I think, what tools can we provide to the VA that they can more effectively compete in the workforce market? And I don't expect you to answer that, but if you have any thoughts, Ms. Cantor?
That's
forgiveness,
a really hard. I mean, that's a great idea, Senator. I think one of the things that this is not necessarily helping with mental health specifically, but it's a model that could be applied. There's a great program out of New York City called Prove that is a peer-to-peer model, and they train their social workers in their social work program to work with veterans, and thereby, in addition to helping a peer-to-peer model, which can again be upstream from other challenges and help people feel connected on campuses, it is training a new workforce of culturally competent social workers. And I think that models like that could be applied outside of the social work space. It's something that could be done. I know that, I don't know the number, but it's my understanding that a huge percentage of physicians are partially trained at the VA because of the high quality care that and program and education that can be offered there. It's surprising to me that it's not a more competitive and place to work that people would be interested in working.
Well, I do think this is something we need to think about. If this is a competitive marketplace, we're going to have to, for example, I learned recently, no one in the federal government is allowed to be paid more than the president. That's $400,000 a year. Try hiring a cardiologist for $400,000. I mean, that's the kind of thing that we need to discuss. We need to talk about waivers and to be sure that we have access to the professionals that we need. Telehealth, Mr. Eaton, you mentioned that. And I don't know if you're aware of the answer to this question. I probably should have asked to the prior panel, but do we have licensure issues with telehealth? If you've got a VA facility in Augusta, Maine, can a veteran go there and get counseling from a counselor in Kentucky? Do you know?
I'm not aware of the VA's approach and what they're able to do across state lines, but I do know through SIPACT there's a growing number, an overwhelming majority of states that are able to have cross-state service through psychology. We leverage that within our Warrior Care Network as well as our outpatient.
Clearly, that's something we need to do. And in my talking with veterans and others, mental health and behavioral health lends itself to telehealth. A lot of people are even more comfortable talking to a screen, and they don't have to wait in a doctor's office and worry about stigma and who's sitting in the chair next to them. And you mentioned they've got to understand their options, but I think telehealth is an opportunity to provide the care nationwide that perhaps might not be available, particularly in a rural area.
Well, 100% agree, and that's what we've seen when we.
I like that on the record. 100% agree. I appreciate that.
When during our survey with our warriors, of those that were offered telehealth services, 90% accepted that, and those that were not offered, only 40% said that if they were offered, they would not have elected that service. So we see it as, again, increasing access, increasing capacity, and it's a positive experience for veterans.
And one of the other, in terms of the providers, what I'm told is there's a much lower level of missed appointments. There's a better getting to the appointments, which is better for the providers. So I do think that's something that we've got to work on. Ms. Kenner, your thoughts on telehealth?
I think I agree. I think that it makes sense for many people. I think that similar to what we were talking about with community care, that it comes down to patient choice, and that if that's something that they're willing to do, that makes a lot of sense. And I think missed appointments in particular is a missed opportunity, and it also, with telehealth, addresses the transportation problem that is a huge cause of that for in-person appointments.
Particularly in rural areas.
Particularly in rural areas.
Great. Well, thank you all very much for your testimony, and I appreciate the work that you're doing. And we're in a learning mode here, so if there are suggestions, ideas, that's what we want to hear, ways that we can try to fix things, whether it could be a law change, but it could also be something that we can work with the VA administratively that doesn't involve a law change. If there are things and we've talked about earlier, you heard us talking about the onboarding and the barriers to bringing new people in. So share your thoughts. We're in the idea business around here. Thank you. Thank you, Mr. Chairman.
Senator King, thank you. Thank you for your full, lengthy participation today.
Sure.
Mr. Eaton, Ms. Cantor, thank you very much for your testimony. Thanks for joining us today. The members of the committee will have 1 week to submit written questions, and we'd ask the witnesses to respond to them as quickly as possible. The committee is now adjourned.